Hi, I'm Carolyn Da Silva. I will be talking with you today about considerations in aging with a disability. I am an associate professor at the School of Physical Therapy of Texas Women's University. If you would like to contact me about questions about this presentation, you may contact me at the email that is on the title slide. I also have clinical work at TIER Memorial Hermann in the post-polio clinic and Memorial Hermann Hospital in the inpatient rehabilitation unit, also in Houston, Texas. This project is funded by a grant from the Health Resources and Services Administration of the Department of Health and Human Services. The grant was initially funded in 2007 with renewed funding for 5 years beginning in 2010. You can see the grant number on the slide. Successful students will be able to understand the organization and levels of the International Classification of Function, Disability, and Health Framework as it pertains to people growing older with chronic conditions. Discuss importance of assessing people aging with a disability at various levels within the ICF framework. Discuss specific barriers and facilitators to health promotion and illness prevention in people with disability. And integrate knowledge into management of patient condition to promote healthy aging. The World Health Organization defines disability as an umbrella term for impairments, activity limitations, and participation restrictions. The International Classification of Function, Disability, and Health, or it is abbreviated as the ICF model, has 3 levels of human function after the initial health condition. So the initial health condition would be something such as headache, it could be stroke, it could be osteoarthritis, or many other diagnoses. And then from there we would look at functioning at the level of the body and body parts, or body function and structure, and problems in this area lead to impairments. And if we go with the primary health condition of stroke in this example, impairments of the body function and structure would be such things as their hemiparesis, or the weakness on one side, spasticity, a sensory loss to the one side. There could be aphasias or difficulties with communication and many other impairments. Also, we were looking at functioning at the level of the whole person, or at the activity level. And so problems in this area would lead to problems with activity limitations or functional limitations. So examples in this particular section would be such things as walking difficulties, falling while walking, difficulties with balance, difficulties with being able to dress oneself and perform other activities of daily living, or caring for oneself at a broader level as far as being able to manage my checkbook, being able to go grocery shopping, and those kinds of things. It would also include driving. Then also we look at functioning at the level of the whole person within the complete environment. And so this is considered the participation level, or participation within society. And so problems in this area lead to participation restrictions or disability. And so this is how the person with a stroke may fit within their entire environment or within society. Are they able to fulfill their roles as a husband or a wife? Are they able to fulfill their roles as a care provider for children? Are they able to participate in social activities that they had been doing before, such as going out to dinner or going to the theater? Are they able to continue jogging? Are they able to resume their work after the stroke? All of those activities would be at the level of the participation, or the whole person within their environment, his or her environment. There's also in this model the idea of contextual factors, and so this includes personal factors as well as environmental factors. So with personal factors, this would be comorbidities. So what are the things that may be coexisting with this patient's stroke, or the things that led up to the person having the stroke, such things as high blood pressure, elevated cholesterol, diabetes, smoking history, those kinds of things. Also within the personal factors would be issues related to the personality. Is this a person who tended to see the world as a cup half full or a cup half empty? You know, a person who can see things more optimistically may have a different recovery pattern than somebody who tended to see the negative side of things all along the way. There's also environmental factors that need to be considered. There's the physical environment of the person. So is this a person who lives in a 3-story townhome with their bathroom and bedroom on the 2nd or 3rd floor with no elevator access? Are there 4 steps up to the front porch with no handrail? those kinds of things. With social support, this would include the family, any significant others. Is this a person that is a member of a church and has been very active with groups within the church? Has this person been very active in their neighborhood and knows their neighbors? And so that kind of support can be very important, as well as the direct family support that can be provided. We also have to consider financial issues of the person. Does this person have savings? Does this person have insurance? And those kinds of things. So why are these distinctions important to make? So let's consider now examples of two 63-year-old females with these health conditions. So the primary health condition that we're going to be most worried about right now is their osteoarthritis, or OA, in both of their knees, their right hip, and lumbar spine. Both of them are overweight, although they are considered non-obese, and both of them have hypertension. So if we look at these two ladies at the body structure and functional level, we can see that they have had their osteoarthritis diagnosed by X-ray. They've had no prior orthopedic surgeries. They report pain levels of 4 to 6 out of 10 in respective joints that are affected with the arthritis with activity, such as walking, but only a 1 or a 2 out of 10 while resting. At this time, they demonstrate strength of 4 or 5 out of 5, which in layman's terms would translate into good or normal strength in both legs, and 5 out of 5 or normal strength in both arms. Their passive range of motion, or their flexibility of their knees and their right hip, or the joints that have been affected by the osteoarthritis, are about 80% of normal. So they are impaired in this area or have some limitation, but it looks like they're getting by pretty well for the most part. Both of them demonstrate a resting blood pressure of 138/85, which does show some early signs of hypertension or some pre-hypertension, and then heart rates of 88, which is a fairly high heart rate, which shows that these ladies are probably not in the best physical condition. Let's now look at Marge and Sue. So when we look at activity levels, then we have Marge demonstrating a slow, painful gait without a device. She demonstrates modified independence in basic and instrumental activities of daily living. She works full-time and she drives. We can say the same thing about Sue. She has the slow, painful gait without a device. She's able to conduct her daily activities independently. She's able to work full-time, and she also drives. However, when we look at the social participation of Marge and Sue, we can see some differences. So Marge is able to fulfill her societal roles as being a wife to her husband. She is able to continue with her full-time employment as a secretary of a large church, so we can anticipate her having a fairly sedentary occupation, although with it being a large church, we don't know how much she may need to chase people down in the church and cover a fair amount of geography, trying to find people to give messages to, and what the structure is with that job. We would need to explore that further. She enjoys hobbies such as reading and fishing, and again, reading is a sedentary hobby, and fishing, it can be sedentary as well, although the preliminary activities related to fishing, as far as loading up the tackle supplies and carrying the tackle supplies and the fishing poles, and what about the cooler, and are they fishing from a dock or are they fishing from a boat and climbing in and out of a boat, and those kinds of things would need to be considered. She's been able to keep up with her housework and cooking, although she has been slowing down because of the pain that she's having in her joints. However, she is having difficulty with her passion for gardening, and she's also having difficulty with caring for her 9-month-old grandson. We know 9-month-old grandsons can be pretty big and kind of heavy, and then carrying an extra load on painful joints can increase the pain. Also, the great amount of bending and stooping that goes with caring for an infant, the diaper changes and such things can be challenging for Marge. If we look at Sue, she is having difficulty fulfilling her societal roles as well. However, her picture is quite different. She's also a wife, but she's a wife of a husband with metastatic bone cancer. So in addition to her having her own health issues, obviously her husband is having significant health issues as well. She's a full-time employee as a daycare teacher of 2-year-olds. So again, this is a job that is far from sedentary. She's going to have to be up on her feet, up and down, up and down. There's the little chairs that the 2-year-olds are using, and We don't know if she is able to sit in a regular sized chair, if she's having to sit all the way down low onto a 2-year-old chair to get more at their level. The 2-year-olds may need to be diapered as well, and of course lifting a 2-year-old is quite different than lifting a 9-month-old as far as body weight and those kinds of things. So she has a very physically demanding job. She also is the primary care provider for their horse and 3 dogs. We don't know at this point if she's still riding and those kinds of things, but dog food and horse food and all that kind of care, all those things are going to weigh a lot for her to be carrying. She is also doing her housework and cooking, but she's finding these hard to complete, again because of her slowness and her pain, and probably some fatigue issues as well. Yard work had been her husband's responsibility, but now it's a new responsibility for her, and she is unable to complete these because of her conditions and everything else she is doing. However, she is a grandmother as well, and she's able to care for her 5-year-old granddaughter. The 5-year-old granddaughter is in good health and is a good granddaughter. The granddaughter likes playing board games, enjoys being read to by grandma, and so she's able to complete this societal role very well and enjoying this. So what are the differences that existed between Marge and Sue? So certainly we see great differences in their environmental situations as far as their physical environment, in that one has a horse, which would denote at least some level of property and having to walk across some pasture or some unlevel surfaces and being able to handle those kinds of things. We don't know anything about actually their homes as far as numbers of steps and that kind of thing. But interpersonally, we have very different situations in that Sue is having to help her husband. We don't know how much she's having to help her husband, if she is simply going with him for moral support for doctor's appointments at this time, or if he's actually starting to require some care. We do know that as his cancer progresses, that he will require more care, and she may be needing to provide some physical aspects of care or having to make arrangements for somebody else to provide the physical care for him if she is unable to do so. From a personal level, we don't know enough about these 2 ladies to know how they are coping with their progressive disability. However, we do know that Sue is going to be under an enormous amount of personal stress, and how she's able to cope and how she's able to stress and find ways to manage her stress will be very challenging for her. Hopefully she was a very optimistic person before to help her get through this, and has significant support from her significant others in her family. So how can a person's status change along the ICF continuum? For Marge and Sue, as their osteoarthritis progresses, which is their health condition, what changes might we see in their body structure and function? So as we see arthritis progressing in these joints, we can see more destruction of the cartilage, which can be seen by X-ray and by MRI. We can see them having more problems with strength if they become more sedentary. We can see more problems with loss of passive range of motion or flexibility, and certainly we can see an increase in their pain. Their activities, as their pain continues to increase, we may see their activities start to reduce. They may choose to stop doing some of their activities because of the pain, because the pain may be too much for them to bear, or they don't want to risk more damage to the joints for those activities. Certainly with the participation, we'll see the same thing. They might start sitting out of some of their social activities and things that they enjoy doing because of simply the need to get the things done that are absolutely necessary in their lives. And then certainly there are contextual factors. As Sue's osteoarthritis progresses, it will make caring for her husband with a chronic disease and a progressive disease much more difficult for her to be able to handle. So what impact might the passing of Sue's husband, which is a contextual factor, have on her health conditions, body structure and function, activities and participation? So obviously at the beginning we would anticipate there to be a significant amount of grieving. There could be some depression that could be very appropriate. The depression could continue on for some time, and it might actually need to be treated. But I would guess that with his health issues going on, that she will probably push her health issues aside and focus much on her husband, which can have deleterious effects to her situation. However, once he passes and she's able to get a handle on things and establish some new routines, she may be able to now focus on her own body and her own health conditions more and seek therapy, get onto some rehab. Hopefully strengthening is not too late to help her if she's going to need a knee replacement, to be able to tolerate the knee replacement well and move on with that. if her pain can be managed either through physical therapy or through surgical interventions, that will enable her to be able to continue with her activities and her participation roles with less pain and hopefully with more vigor. So measurement of health conditions. So what types of measures or tests do we use? This would include differential diagnosis. So again, this is the primary diagnosis. So how are these primary diagnoses derived? So this could be something as simple as a differential blood test of some kind. It could be through X-ray. Certainly we have access to MRIs, CT scans, and those kinds of things. We also look at measurement of body structure, function, and impairment. So we need to distinguish between primary impairments and secondary impairments. So with primary impairments, these arise directly from the health condition itself. So examples of this after a stroke would be the weakness, spasticity, and sensory deficits that derive completely from the stroke itself. However, there's also the idea of secondary impairments, and these may indirectly arise if spontaneous recovery and/or therapeutic interventions are insufficient. An example of this would be an ankle plantar flexion contracture or Achilles tendon shortening or deconditioned cardiovascular state from residual hemiparesis over time. So if this person is not able to walk very well, they're not going to walk, and then that will cause them to become more sedentary and then more deconditioned. Also, if they're not up and walking very well, and or they have spasticity that is not controlled adequately and have not been exercising with stretching, they can develop the contracture that will make walking all the more difficult as well. So when we're measuring body structure and function impairments, what types of tests and measures can we use? So it's very common for us to be doing such things as measuring vital signs, heart rate, blood pressure, respiratory rates, those kinds of things. Also, more specific to the patient with a stroke or with our conditions of osteoarthritis, we'd be measuring muscle strength. We can measure muscle endurance. We can measure flexibility of the muscles and joints. We can measure sensation. We can measure spasticity through such things as the modified Ashworth scale. When we measure activity, again, we can measure these, and what are some examples of measurements or tests that we can use for this? This can be as simple as a 10-foot walk test or a 10-meter walk test. We can also have walking endurance measures such as a 6-minute walk test for patients who are able to walk. These tests are used very widely for patients who are ambulatory. We can look at balance, and balance is measured in a variety of ways, and that's a whole nother lecture in and of itself. But such examples would be the functional reach test, the timed up and go test, the Berg balance scale, such measures as those. There's also measurements of activities of daily living. There is the FIM, which stands for the Functional Independence Measure, that measures everything from continence and toilet transfers and walking and locomotion to some aspects of communication. So let's look at gait speed for just a moment, and there is some evidence in the literature that gait speed might be considered a new vital sign. Gait speed has been associated with survival in elders. The predicted survival of almost 35,000 elders based on age, sex, and gait speed was as accurate as that predicted by age, sex, use of mobility aids, self-reported function, or age, sex, chronic conditions, smoking history, blood pressure, body mass index, hospitalization. So again, a simple 10-foot walk test and measuring their gait speed in that short of a period of time has been deemed to be a very important predictor of mortality. A speed of 0.8 meters per second or 1.79 miles per hour indicates average life expectancy. So those people who are able to walk at a faster walking speed than this speed reported would indicate that they would have the ability to live longer than average life expectancy, and those people who walk at slower rates of speed would indicate shorter life expectancy. So let's keep gait speeds in perspective. Jacqueline Perry was an orthopedic surgeon who categorized functional walking in people with chronic stroke according to gait speed, and she labeled the people that went at 0.27 meters per second as unlimited household ambulators. Those that walked at 0.58 meters per second were limited community ambulators, and those that walked at 0.8 meters per second as unlimited community ambulators. And again, the 0.8 meters per second is the same speed as that predicted average life expectancy. But if we take these numbers from the stroke survivors and compare those with average older adults, we can see that still even the more highly functioning stroke survivors are walking at significantly less speeds than older adults. If we look at adults 20 to 69 years old, they are walking at approximately 1.3 meters per second, or about 3 miles per hour, and there is some variability between males and females, with males tending to walk a little bit faster, and this has to do generally with their higher height or physical stature. Adults 70 and older tend to walk at 1.1 to 1.2 meters per second, or 2.5 to 2 3/4 mile per hour. And again, this is significantly slower than the unlimited community ambulators in the stroke survivor population. We also need to keep in mind the speed needed to cross a commercial street at 2 meters per second, or 4.5 miles per hour. Measurement of participation. So how do we do this, and what areas does this address? What areas might be avoided or not thought about? So this is where we get into things such as quality of life, burden of care. We can also think about mood and emotions, so such things as depression and anxiety. So there are a variety of measures that we can use for this. For stroke-specific quality of life, there is the Stroke Impact Scale, which is widely used. There is the short form 36 or SF-36 that measures various aspects of quality of life. And certainly with mood and emotion, there's a variety of measures such as the Geriatric Depression Scale, and then there's the Hospital Anxiety and Depression Scale as well. So we are seeing a paradigm shift from disability prevention to prevention of secondary conditions. So certainly prevention of disability has been on the forefront for many, many years. This would include such things as mandatory seatbelt laws, mandatory helmet laws, and those kinds of things to prevent severe injury such as spinal cord injury and traumatic brain injury. But now we are seeing that there are a lot of people that have sustained disability either due to injury or due to illness, and they are surviving and they are living, and now we are seeing them age. And that sets them up to have more issues with secondary conditions. So prevention of these secondary conditions is quite important. So the aims of a health promotion program for people with disabilities are to reduce secondary conditions such as obesity, hypertension, and pressure sores, maintain functional independence, provide an opportunity for leisure and enjoyment, and enhance the overall quality of life by reducing environmental barriers to good health. Dr. Rimmer also recommends that a greater emphasis on community-based programs is necessary for this to actually happen. So Dr. Rimmer et al. In 2011 defines a secondary condition as it occurring after an individual acquires or is born with a disability. The characteristics of the condition are not associated with the trauma. It is more prevalent in people who have a disability than in those who do not have a disability. It is not caused by medication or intervention, and so examples of this would be medication side effects. And it is a health condition versus a risk factor for a health condition. So let's back up a minute and look at old versus new definitions of health. So health is no longer defined as simply the absence of disease. The World Health Organization defines it as the well-being of the person within these domains: physical, mental, and social. And certainly we can see how there are dynamic interactions of these domains, and includes the person within the environment. Each of us can think of a variety of patients that have significant physical disability, but mentally and socially they seem very healthy in that they're very adjusted, they get along with people, they're happy, they're productive, either in work or volunteer activities, and so on. We also have a variety of patients who have a relatively minor physical disability, but they are mentally less healthy, and that can certainly impact their physical state and cause more problems as well. And they need to be managed in very, very different ways. So when we look at the dynamic aspects of health, we need to remember that, again, health is multifactorial, including the physical, the mental, and the social aspects, and it does shift along the continuum of life. An example of this would be my recent experience with breast cancer. I'm a young professional, although now I'm actually middle-aged, but I have been full-time employed. I had been a single mother. I was raising 2 daughters at the time. One was in middle school and one was in high school. I was physically active with exercise. The only risk factors that I had for breast cancer was that I was female and that I was getting older. And then, so I had to have a number of surgeries, I had radiation treatment, and during this time, I had difficulty maintaining all aspects of my work, but I had a very supportive work environment during this time. I also realized that I had a lot of people in my life, such as my family and my significant others, such as friends and coworkers, that really rallied around and helped me through the process by simply providing meals at times, providing gift cards for meals, those kinds of things. And so it really helped me with my social support to remain mentally strong, and I wanted to keep things as normal for my children as possible with their busy schedules and so on. So a person with a disability will have dynamic changes in health during his or her life as well. However, a minor condition can affect a person with disability more severely than one without a disability. A classic example would be somebody who undergoes a rotator cuff repair for a person who uses a manual wheelchair or crutches full-time. If this person is under movement and or lifting restrictions because of the surgery, he or she will not be able to push the wheelchair or use their crutches, and that can be a significant issue. Fairly recently, I had a patient in the clinic, in the post-polio clinic, who had been walking full-time using bilateral knee, ankle, foot orthoses or long leg braces and bilateral crutches. She had significant shoulder pain in both arms, and she was considering having surgery because her doctor felt like that was the only thing that would help her with her shoulder pain, and she asked if she could have both of her shoulders operated on at the same time. And I am a physical therapist, and I reminded her that I'm not a surgeon, so a second surgical opinion would not be in my scope of practice. However, I asked her about the realities of her life, in that if she had both shoulders operated on, how would she be able to transfer? Because of her profound leg weakness, she was not able to use her legs very much for the transfers. Again, she was wearing the bilateral long leg braces because of the severe weakness or paralysis. And she said, well, I'm planning to hire somebody for 3 hours a day to help me. And I said, well, 3 hours a day is well and good for those 3 hours, but you need to use your arms for transferring to the toilet. And if you have bilateral shoulder precautions where you can't lift or push or pull during your early recovery time, that means if you don't have anybody there to help you outside of that 3 hours, you're not going to be able to go to the bathroom or toilet for the other 21 hours of the day. And she had not thought of that, and that was not really brought to her attention by her surgeon. I recommended that if she were to do both shoulders at the same time, that she would need to make arrangements if she didn't have anybody that could stay with her to help her in her social support network, to consider having herself placed in a skilled nursing facility or a nursing home where she would have the availability of people to help her with toileting and other things. So what are the typical aging processes? We see this all the time. So we know that as people age, they lose muscle cells and they lose muscle strength, that they can develop some muscle atrophy with the normal aging process. We also lose nerve cells during the aging process. We may lose some sensitivity of feeling. Our vestibular system, or our inner ear or equilibrium system, also has numerous nerve receptors, and we can lose sensitivity of that system's functioning. Certainly as people get older, we see more people wearing glasses. We have issues with hearing problems, and there can be issues with balance and these kinds of things. So how might these be different in people with disabilities? The main issue is that people with disabilities may be compensating for their, for example, leg paralysis by using their arms more or using other body systems to complete their daily activities. And with normal aging and normal wear and tear, then their compensatory strategies may develop problems and may not be functioning as well, and so some of their compensatory strategies may start to fail them. We see this frequently with people that have chronic disabilities. So this is a quotation from a patient. "The lack of knowledge and understanding on the part of healthcare professionals concerning my disability and how it has affected me as I age is extremely frightening to me." So why the paradigm shift into working with people and trying to prevent secondary conditions? First and foremost, people with disabilities are living longer and some have normal life expectancies. Modern medicine has allowed more people with severe impairments to live and then age. Up to 50% of polio survivors develop post-polio syndrome. About 25% of people have been reported with spinal cord injury have increased functional limitations more than 15 years later. Secondary conditions are a prevalent public health concern. Individuals with physical disabilities are at high risk for secondary complications and conditions and have higher frequency of conditions. We also know that there are certain precautions that are important with people with disabilities. Such things as people with multiple sclerosis need to avoid becoming overheated. So if we're asking them to start an exercise program or a walking program, we need to give them guidance for how to do this safely. Examples of this would be for them to work out in an exercise gym versus having a gym in their garage. If they're going to walk outside, for them to be very careful about the time of day that they're walking and or to wear a cooling device while they're walking, and also to keep cold fluids with them while they're working out. Also, people with spinal cord injury need to be careful with overheating in that if they have a complete spinal cord injury, they are not able to make goosebumps or to sweat below the level of the injury. And so their normal bodily systems for cooling or heating their bodies are not as efficient as people without spinal cord injury. There has been a government push to improve the health of people in the United States that started actually back in 1979 with the Surgeon General. But there has been task forces along the way that have developed the Healthy People. At this time we're functioning under Healthy People 2020, but previously we had Healthy People 2010 and Healthy People 2000. And prior to 2010, this document did not have disability-specific related issues. However, because it has come to the forefront to the federal government, it has been included in subsequent editions. And it can be found on this link. This link is an active link for your perusal. So the prevalence of disabilities. It is estimated that 20% or 54 million Americans are disabled, and there has been a significant increase in younger populations since 1970. A lot of this likely has to do again with the modern technology and good emergency care, both with survival of premature infants as well as improved care with trauma and early diagnosis of hereditary and other types of conditions. There are disparities, however, that exist in physical activity levels between people with and without disabilities. Obviously, people that have movement-related disabilities or physical disabilities have a more difficult time with movement, and it's harder for them to remain physically active. There's also disparities in the proportion of women and minorities with disabilities, and this does require more research as to why this exists. Women with and without disabilities have similar health behaviors except for that of exercise. So a survey was done of 604 women with various kinds of disability, and they were looking at health promotion topics that these ladies were interested in. And you can see at the top of the list, aging with this disability was their first topic of interest. After that, we find stress management, exercise, nutrition, general health promotion, and mental health issues. Of least interest was smoking cessation and reproductive issues. So let us look more at secondary conditions. So it is believed that these secondary conditions are related to physical inactivity, and these secondary conditions can actually worsen the disability itself. So first, diabetes. There's a 3 to 4 times incidence of diabetes in people with disabilities than in the general population. There's an increased amount of heart disease in people with disabilities, and part of this has to do with, again, the physical inactivity as well as having weak or paralyzed muscles and less muscles to help return blood to the heart and less cardiac output. There's also the issue of osteoporosis, in that some patients and some patient populations have insufficient muscle mass active to keep bones strong. So classic examples of this would be people with spinal cord injury, polio survivors, and other disorders like that. We also need to consider unilateral and bilateral issues with these patients. For example, with the post-polio population, Primarily, I'm working with people who are in their late 50s, throughout their 60s, and then into their 70s, 80s, and occasionally into their 90s. If they are not able to walk because of their weakness, of course they will be at higher risk of osteoporosis. But there are also people that are full-time ambulators that might have one leg that is strong or relatively strong and one leg that is very weak. And some of these patients might have severe weakness in the one leg with a leg that is no bigger than his forearm or my forearm. And it's important that when they do get screened for osteoporosis, for them to get screened not only in their lumbar spine and one hip, but also to get screened in both hips. And I do provide this level of education for patients in the clinic on a routine basis. And the reason for that is if the very weak limb is not scanned, there could be osteoporosis in that area because, again, the lack of muscle activity that can pull on the bones to help keep the bones strong. And so osteoporosis could be undertreated with those patients. However, if only the weak limb is scanned and not the stronger limb as well, osteoporosis could be overtreated as well. So that is for the patient to discuss with their primary care provider in that area. Obesity is significantly more prevalent in people with disabilities, and we also see more disparity in obesity noted in women with and without disabilities. So let's take a minute and look at secondary conditions after stroke. Dr. Ivey et al. Conducted a study, and they found that in 98 people that were 24 to 180 days following stroke, so less than 1 month to 6 months following stroke, again, this is still in the acute and the initial subacute phases after stroke, with no prior history of diabetes, that 52% of them had impaired glucose tolerance or diabetes type 2. Again, this is people with no prior history of diabetes that led to having the stroke, that 52% of them had impaired glucose tolerance or diabetes. Also, they found that in 216 people with chronic stroke and no previous history of diabetes, that 81% of them had impaired glucose tolerance or diabetes type 2. So this is a huge percentage of increase after stroke. They're attributing this quite a bit to muscle fiber changes, so let's talk about this for a minute. Muscles normally have approximately 50% fast twitch and 50% slow twitch muscle fibers, physiologically. However, after stroke or spinal cord injury, there's a big switch in that there's a decrease in the number and the percentage of slow twitch muscle fibers. We know that fast twitch muscle fibers are less insulin sensitive. Fast twitch fibers muscles fatigue more easily, and so the patient that has more fast twitch muscle fibers is going to fatigue more rapidly, and then they're going to get tired and they're going to rest more and then become more sedentary. What they found was that the affected leg demonstrated 67% fast twitch fibers and the unaffected leg approximately 51% fast twitch fibers. Why this is so significant is that if we have normal populations that have aggressive training, such as elite athletes, we will see a 3% conversion of fibers towards slow twitch or fast twitch, depending on what kind of sport the person is training towards. So we can see that the 67% is much higher than the 50 or mid 50 range as far as percentages. With greater degree of impairment, this indicates a greater switch to the fast twitch fibers and then also a greater insulin resistance. They also found that the paretic leg, when compared with the non-paretic leg, showed fat content to be 25% higher in the paretic leg and muscle mass to be 20% lower. They also found that the fat content of the paretic leg is a higher predictor of insulin resistance than central obesity. And we know that central obesity is a huge predictor of insulin resistance and other metabolic problems. They conducted a treadmill study with individuals with chronic stroke. It lasted for 6 months, 3 times a week, and they found significant improvements in insulin sensitivity, slow to fast twitch fiber ratios, blood flow. They also found changes in fibrinolytic markers for at least 1 hour after exercise. They found changes with increased TPA, and as we know, TPA is the big clot buster medication that is delivered after an ischemic stroke if the person is able to get to the emergency center in 3 hours. They also found a decrease in a substance called PAI-1, which is a bad marker, so having a decrease in this marker is a good thing. They also found that these changes are not seen in normals after exercise, and they indicate that this presents evidence of an inflammatory process after stroke. They also argue that the exercise may help protect against new stroke or exertional myocardial infarction because of the changes in those fibrinolytic markers. Even though these people experienced these significant changes with the items that have just been expressed, they found no changes in body mass index or percentage of fat. So how unfit are stroke survivors? They tested 156 full-time community ambulators with a mean age of 67 years and a mean time since stroke of 3 years. They found that the hemiparetic gait cost twice as much as normal. They also found these stroke survivors to have fitness levels that were 50% lower than age and gender matched sedentary controls. And again, these are people that are full-time community ambulators. These are people that are going to the malls, going to ball games, and those kinds of things. This is not including the people that may be only walking within their homes or around their homes and using wheelchairs out in the community. So why are they so unfit? Primarily, we have the issues of the altered central nervous system motor control with difficulty activating the muscles as the muscles were designed to be activated. Again, there's also the secondary biological changes in the muscle and fat composition that has been presented, cardiovascular deconditioning from not getting up and moving as much, and plain old disuse. So Dr. Rimmer et al. In 2011 published an article called The Conceptual Model of Onset Course and Outcomes of Secondary Conditions in People with Disabilities. I would like for you to pause the video at this time and access this article so that you can have the figures side by side as we go through the rest of this lecture. So first he discusses the primary disability. So this would be the conditions such as the spinal cord injury, the stroke, and those kinds of things. So then we look at the onset and course of the secondary conditions. And he talks about the non-modifiable antecedents, or the things, the precursors to the primary disability. So this would include socio-demographic areas such as age, gender, ethnicity, living situation, a level of education and such. Also pre-existing conditions. Is this a person who had a pre-existing shoulder injury? Is this someone who had baseline of diabetes already or hypertension? Those kinds of things. Then there's the disability-related antecedents. So this would be the type, severity, and duration of the disability. And then there's the associated conditions. So this includes concurrent health impairments related to the disability, and this would include things such as spasticity, presence of seizures, and that kind of thing. So then we look at modifiable risk factors, and those have been divided into personal and environmental risk factors. So in the personal risk factor section, this would include things such as overuse or disuse. So we see overuse syndromes frequently in people who are pushing wheelchairs full-time, such as people with spinal cord injury or polio survivors. We see disuse when people are not using their body to its fullest potential. We know that diet is a very important part of health, and if a person has a poor diet, either because they're not eating enough or they're eating too many fast foods or overly processed foods, or alcohol use, those kinds of things, that can contribute to their risk factors as far as if they do have an injury, how they can heal from the injury and be healthy. Medication adherence can be a big issue. Is this person compliant with the medications that have been prescribed by his or her physician? If the person's not adherent, why are they not adherent? Do they not understand why they're supposed to be taking the medications? Can they not afford it? Have they not sought access to free medications or try to get cheaper generic equivalents, those kinds of things? Physical activity, again, a lot of people with disabilities are less physically active than people without disability. What about rehabilitation adherence? Have they been compliant with their therapy appointments and fully participating in their therapy appointments? Have they been compliant with following through with their home exercise programs? Or have they taken it upon themselves to quit? And certainly the issue of substance use and substance abuse can be a complicating factor as well. So other modifiable risk factors include environmental risk factors. We have such things as health care, and a person with a disability can have reduced levels of health care or poor quality of health care. There's also, related to this, would be a woman who is using a wheelchair full time for all of her locomotion. She is not able to stand to transfer, and she's trying to access well woman care, such as her gynecological visits as well as mammograms, and she is not able to stand in the mammogram machine, or she's not able to perform a stand pivot transfer onto the high examination table in the gynecologist's office. So those can be big challenges for people. There's also environmental modifiable risk factors. The first one is healthcare, and this would be having reduced levels or poor quality of healthcare. It can also be lack of transportation to the healthcare. An example of having reduced levels or poor quality or poor choice would be an example of a woman who would like to undergo her well woman examinations. However, this person is using a wheelchair full time. She's not able to use her legs to walk or to perform a stand pivot transfer. She may have difficulty accessing a mammogram machine because she's not able to be in a standing position. Also, she might not be able to perform a transfer onto an examination table for a gynecological exam because of the height difference between the table and her wheelchair. There's also the issue of lack of health promotion access. If they're not getting the information that they need and how to be as healthy as possible. Built environment access is a huge issue in that sometimes homes are not very accessible, sometimes doctors' offices are not very accessible, so these can be big issues for patients. There's been a number of patients' homes that I have gone into where it was a little bit dangerous for me to enter and exit the home, much less this person that has a significant limp or using a wheelchair. Also, the idea of social support. Again, there's some people that have a whole lot of social support, be it their spouses, parents, children, or close friends, but then some people really don't seem to have another person in the world that is able to help them. So when we look at outcomes of secondary conditions, and if we continue to look at the article by Rimmer and continue to look at the bottom of Figure 2, we can see that he presents the onset, progression, and severity of the outcome of the secondary condition. We need to also look at things using the ICF model from the body structure and function level, the activity level, and the participation level. From there, he divides things into individual level outcomes or micro level outcomes and societal level outcomes or macro level outcomes. And so at the individual level, we have that person's health-related quality of life. We have healthcare utilization, how much they're utilizing the healthcare system, such as how many doctor's appointments, tests, and things that they're going through. The person's ability to fully participate in the community. Is this person still able to do the things that he or she wants to be able to do as far as leisure activities, volunteer activities, and certainly work? We also have the societal level outcomes, and this would include cost of health care. So certainly at the personal level, the person is going to have health care expenses as far as co-pays and deductible. However, we also see things at a societal level because people are paying insurance premiums, people are paying taxes into the Medicare system, and those systems and those companies are paying what we don't pay. There's also the health disparity. People with disability tend to have more risk of secondary conditions than other people by definition. So this article presents a case study of a Mr. C, who is a person with a spinal cord injury who has tetraplegia, and this person now develops shoulder pain. So Mr. C's non-modifiable antecedents include his age, Also his history of a previous shoulder injury related to overuse from before, as well as a fall where he injured his shoulder. He has tetraplegia. He also has limited trunk control, so he has partial use of his arms because of his spinal cord level, and he has limited trunk control. He also has no ability to use his legs. His modifiable risk factors include, again, the personal and the environmental aspects. So at the personal level, we have the overuse of the shoulder, and this is from his multiple transfers that he performs in a day, his wheelchair propulsion, also his ability to conduct pressure relief to prevent pressure ulcers. There's also the time of his wheelchair use. How much is he up in the wheelchair and using his wheelchair all day, and does he take breaks by lying down? Certainly people who are working full-time generally do not have the ability to lie down in the middle of the day. Environmental risk factors would be propelling the wheelchair on inclines. Does he have to go up and down a driveway? Does he have to access wheelchair ramps, wheelchair curb cuts? Certainly some patients have to be able to jump curbs and that kind of thing. So when we look at his secondary condition of shoulder pain, and we look at it from the body structure and function standpoint, we're looking at his muscle strength and being able to strengthen his available muscles. And then also, if he has developed some flexibility issue related to his overuse and or pain, we can help him to become maybe more flexible as well through exercise. His secondary condition of shoulder pain will also impact greatly his ability to perform his ADLs, his transfers, and his wheelchair propulsion. So he has been independent with being able to dress himself, bathe himself, perform his cathing schedules and those kinds of things, but with his shoulder pain, that's going to impact all those activities. Also at the participation level, will he be able to continue with his social activities and things he likes to do for fun, as well as continue to work full-time? And working full-time can be hard when you're having to manage therapy appointments and doctor's appointments and special tests. So when we look at individual level outcomes for Mr. C, he's demonstrating that he has decreased health-related quality of life, decreased community participation, and decreased ability to work. He also has increased healthcare utilization, and he has increased cost of healthcare due to his amount of co-pays that he's having to do. At the societal level, he has increased cost of healthcare and health disparity in that his shoulder problem has a higher prevalence in people with spinal cord injury than it does for people in the general population. So when we look at prevention to intervention strategies for Mr. C, we do want to help him heal from his current shoulder injury, but we also want to prevent future shoulder injuries as well as other injuries for him. So at the rehabilitation level, in addition to actually treating him for his shoulder pain, whether it's a tendonitis, bursitis, or whatever, he will need physical therapy for that, but we can also fully evaluate his wheelchair propulsion mechanics. There is much research on proper arm position relative to the wheels, where the wheels are placed, how high the wheels are, where the person accesses the wheel, and the axle alignment related to the wheelchair and the person's body position in the wheelchair. So he probably needs to get this reassessed. Sometimes patients leave wheelchair seating clinics with optimal situations for that particular point in time, but then as they become more functional, more independent in the community, their needs might change, but they might still be using the same setup that they had been using before. Also, as a person gets older, they might be using the same type of wheelchair that they had been using, for many years, and not recognizing the need to switch types of wheelchairs and alignments and those kinds of things for optimal health. With health promotion, he would get an exercise program and therapy, and then hopefully he would continue this exercise program to maintain the health of his shoulder after he's discharged from outpatient physical therapy. Is he using assisted technology to its fullest advantage? An example of this would be power assist wheels on his wheelchair. There are very ingenious wheels that are mounted onto a regular lightweight wheelchair that when one pushes it with a certain amount of effort, the wheels can be set to actually propel the person twice as far or 3 times as far as a normal push stroke would do, and he might qualify for this, especially with the incidence or the occurrence of a shoulder injury. Also, is he in the lightest weight wheelchair that his body can handle, because we know that pushing more weight in a wheelchair as well as body weight can set the patient up for shoulder overuse injuries as well. He might also need a work ergonomic evaluation to make sure that his workstation is optimal to help prevent carpal tunnel problems as well as shoulder problems. Also, related to intervention, we have the need to advocate for our patients and to teach our patients how to advocate for themselves. So advocacy for durable medical equipment, which is DME. Again, that's durable medical equipment. Insurance companies and Medicare are not likely to pay for things that are costly. They would rather pay for the lower cost versions of things than the higher cost versions of things. So it's important for us to teach our patients and for us to help advocate for our patients and to document the reasons why they need some of the higher technology and therefore more expensive items. Also, for us to advocate for them to be able to have affordable fitness memberships at gyms. And we'll talk more about this in a little while. So what are the barriers to exercise? What are your personal barriers to exercise? Or are you getting a sufficient amount of exercise to maintain good physical health? Many of us, when we reflect, can find many excuses for why we're not exercising, or why we're not exercising enough, or why we're not exercising as much as we should. Frequently, people will report lack of time, lack of motivation, lack of energy. You know, it's too hot, it's too cold, it's raining, it might rain. All these are excuses or barriers to exercise. So we'll talk about this concept in a little bit more. So there are different types of barriers and facilitators to exercise, and this has been discussed in an article by Myers et al. And so we will discuss these barriers and facilitators at the internal, interpersonal, and environmental levels. So internal barriers and facilitators are the things that are unique to that particular person, the individual. So this would be, what is the person's fatigue levels at the end of the day when they're attempting to exercise? What is their personal health? Do they feel well enough to actually undergo an exercise program that afternoon or that evening? What is their internal motivation, their drive to be able to do? They want to lose a little bit of weight? Do they want their body to look a little bit better? Those kinds of things. And different people will have different motivational aspects. So with interpersonal factors, those can be barriers and facilitators as well. So examples of facilitators would be if the person has somebody with whom that they can work out. So we know that exercise buddies or running buddies are helpful to keep one motivated to continue with the exercise. It's more fun, there's some social interchange, and also you don't want to be embarrassed by being deemed the lazy one of the pair. So there's those kinds of subtle pressures or explicit pressures that can be put on a person. Similarly, it can be interpersonal barriers can exist in that if I'm wanting to go out and exercise, but my significant other is very comfortable on the couch watching a TV program that happens to be one of my favorite TV programs and has a bowl of popcorn going, and that couch looks very comfortable and I'm tired from work, that can be a motivator for me to stay at home and watch the movie with my significant other and eat the popcorn rather than get out and exercise. Also, if I don't have anybody that can care for my kids while I am exercising, that can be an issue as well. Something else that we might see would be if a person with a disability goes into a health club and people stare at the person because they're not walking normally or they're in a wheelchair, they might perceive some rudeness and those kinds of things, or maybe the healthcare professionals seem to be ignoring them or treating them rudely. That can be a huge barrier for exercise. We know there's an enormous number of environmental barriers as well. You know, if the person lives in a neighborhood with no sidewalks, or if the sidewalks are very old and cracked and are going in all different directions because of lack of maintenance and or old trees. Also, some people live in neighborhoods that may be unsafe for them to do exercise outside. They might be fearful of getting attacked. Again, is it too hot to exercise? Is it too cold to exercise? Is it raining? And even if I want to maybe go into a large shopping mall or a large store to do my walking program, if it's raining, how protected is it going to be for me to be able to get from the car to the shopping center without getting completely soaked? That can be a huge issue. So Rimmer, again, studied barriers for African American women with severe disabilities, and this population of women were in a poor area of Chicago, and there were 50 women that participated in the studies, and their most frequent conditions were arthritis, stroke, and multiple sclerosis. Dr. Rimmer and his associates developed a new instrument to measure barriers to physical exercise and disability that included these numbers of questions, and they conducted it through a phone interview. So what they found was that 82% of the women reported that they liked to exercise. A lot stated that they wanted to begin an exercise program. 72% said that exercise would be helpful for them. 72% reported not knowing what kind of program they could get to, and 62% denied having concerns about exercising in a fitness center. 5.3% believed the facility would not have an instructor that would be able to help them. Most denied a fear of leaving home. Most had been instructed by their physician to exercise, and most were aware of what types of activities to perform. The women also reported their most frequent barriers to exercise to be the costs of programs, insufficient energy to perform the exercise program, lack of transportation, and not knowing where to go. These are barriers that are different than that reported by the general population, which are lack of time, lack of motivation or interest, or laziness. However, the barriers that these women reported were similar to that reported by patients with spinal cord injury, with the exception of transportation. The lack of transportation was last on their list, but the patients with spinal cord injury also reported lack of motivation, lack of energy, costs, and not knowing where to go. The transportation difference is probably due to different demographic variables. There's also the importance of caregiver support. There was a study that was done that looked at a 12-week aquatics program for people with progressive multiple sclerosis. You can see that a lot of people actually did not complete all 24 classes for this particular program. Out of the large number of total missed sessions, the most frequent absences were due to medical or physical symptoms. This was followed by transportation difficulties, social conflicts, and significant other not being available. So obviously the significant other not being available would probably be related to transportation difficulties, but also when we're considering an aquatic program, there's the issue of changing clothes in a dressing room and those kinds of things, and some of these patients might have needed help with that kind of thing. The social conflict reason was not a social conflict as far as an argument with a spouse, but it was more of a social conflict of, oh, I'd rather go have lunch with my friend than go to the exercise class for today. The importance of caregiver support has also been reported in a study with adults with cerebral palsy, and stresses and needs of caregivers of stroke survivors have been explored qualitatively. So when we start to look at shifting away from clinics and more towards a community, a study has been done that reviewed fitness centers in Kansas and Oregon. None of the centers were 100% compliant with the Americans with Disabilities Act standards. Now, please note that this article was published in 2004, and the Americans with Disabilities Act was first enacted in 1990. So, although the act was relatively new, there was still at least 10 years for centers to become compliant, and certainly new centers to be built to meet the existing laws. What they found in this study was that 8% of the equipment areas were accessible to the patient. That's not a typo, that's 8%. So when they did a qualitative study looking at barriers and facilitators to, what could make it easier for people with disabilities to use the fitness centers. And so the barriers that they found included lack of accessibility into and within the center. And so the related facilitator to that would be to build new centers to ADA standards, and trying to remodel or rearrange things to allow things in existing centers to be compliant with ADA standards. And I just recently had a discussion with a young man who had visited some fitness centers in his community, and he said that the fitness equipment was fairly accessible, and when he talked to the personnel there, they said they had actually removed a few pieces of equipment to make room for people with mobility problems to be able to access. However, he also reported that apparently there were some complaints with some of the equipment being moved from some of the other people that wanted to use the equipment. There's also the issue of family changing rooms, in that if the person needs to utilize the changing room for showering or going to the bathroom or simply just changing clothes, and they need help from their spouse, certainly the couple cannot go into the women's dressing room because there's a male involved, and they can also not go into the men's dressing room because there's a female involved. So having the presence of the family changing rooms is convenient not only for families with young kids, but also for couples who are trying to engage in fitness activities. Something as simple as non-slip mats can make things very, very easy as well. There's also the cost of programs to people with disabilities, and of course costs were reported by the women that were studied, as well as the people with spinal cord injury. And so when I'm talking with patients, I encourage them to ask for free trial memberships at gyms. That way there's no cost up front, and they can see what kinds of equipment they can use, what parts of the facility they can use, and see if it's going to be worth it for them. I also encourage the people with disabilities to ask for a sliding scale for payment, because we know that many people with disabilities make less money than people without disabilities. There's also lower rates of employment and a greater amount of unemployment in this population. So even a $30 a month membership fee can be cost prohibitive for patients. There's another barrier would be the cost of adaptive equipment and training on how to use the equipment. And related to this would be lack of information with people with disabilities and fitness personnel. So having a few pieces of equipment that can be accessed from the wheelchair would be an important factor, as well as there are some pieces of equipment that are designed for people who are using wheelchairs. Personnel need to be trained in how to help patients, for them to be knowledgeable. I'm a little bit aware of training to become a personal trainer, and apparently there's a new certificate that is provided for people that have some of this specialized training. But also, fitness personnel and people that run the health clubs need to seek input from people with disabilities regarding types of equipment and things that would help them to maintain an exercise program. Lack of transportation is another barrier that has been reported by some populations, and then being able to explore some transportation options would be a good facilitator. So when we look at the fitness and wellness continuum, we start with rehabilitation and then we work our way down. So again, rehabilitation would be inpatient. It could also be outpatient rehabilitation. It could be rehabilitation within the home, depending on the person's unique situation. But it's going to be carried out by doctors, therapists, nurses, and a variety of different care providers. The idea would then be, when those services are discontinued, for the person to maybe go to a clinically supervised health promotion program, which could be at a hospital or university-based center or in a private clinic. Again, there might not be health professionals that are actually doing this. It could be exercise physiologists, they could be personal trainers that are running these programs, but the idea would be to have access in those areas. Then from that, looking at community-based health promotion, again, looking at fitness centers and community centers, because the fitness centers and community centers are closer to where the people are actually living, and transportation may be less of an issue. So for this model to be successful, fitness and wellness professionals must enhance their knowledge and skills in health promotion and disability. Rehab professionals must extend its services into fitness and community centers. And funding sources must start paying for memberships and consultant services for health promotion programs for people with disabilities. And we need to remember again that people with disabilities generally have less income. There's also a website by the National Center on Physical Activity and Disability. And the link that's on your slide is an active link, so feel free to explore it at your leisure. It has videos of various types of people doing different types of exercise or physical activity, and it can be actual real exercise for strengthening and conditioning, or physical activities such as scuba diving, bowling, skiing with disability, and those kinds of things. There are also instructions and commentaries that are available. So I'd like to thank the Houston Geriatric Education Center for their resources, support, and encouragement for this project, and the many patients and clients who constantly provide stories, inspiration, and challenges.